Well, hello, everyone. Welcome. This is Eric Glazer, and you are watching and listening the live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders like the ones you see in front of you today to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations across the land. Our goal is to identify as many of these bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you are new to the show and you have not yet subscribed, I encourage you to do so. We got unbelievable guests with an unbelievable amount of information to share. Can only help you do your job better. Subscribe, go to Bright Spots in Healthcare, any podcast app that you like using, you should be able to find us, and please click subscribe there. Our topic today, the evolution of specialty based care. We have a terrific panel organized for you today. I'm not going to introduce them by bios to save time, as we always do, but if you're listening to the podcast, in your show description, there's going to be a link to their bios. And if you're watching here live via Zoom, our producer, Gene Ware, is going to post a link to those bios right in the chat so you can get a sense of the experience and expertise you're about to benefit from. Our panelists, in no particular order, are Dr. Alexander Ding. He's the Associate Vice President of Physician Strategy and Medical Affairs at Humana, and Nick Lefeber, the Senior Vice President of Value-Based Care, Contracting, Data, and Analytics at Blue Cross Blue Shield of Rhode Island, and Rachel Winokur, the Chief Executive Officer at TailorCare. So welcome all to today's episode. Our newest partner in the Bright Spots family, and we cannot produce these weekly shows for all of you, and we've been doing it for over 10 years, folks, without the incredible support of our sponsors and our corporate partners. TailorCare, I'm going to tell you a little bit more about them later on during today's episode, but they are a risk-based care navigator, and they provide a risk-based navigation program that provides deeply personal support to consumers living with joint, back, and muscle pain. Like I said, I'll tell you a little bit more about what they do and how they do it later on in the episode. All right, here's how today is going to work. We're going to start the interview talking about some of the core principles around value-based care and value-based strategy with a lean towards specialty care. Then we're going to talk about the applications of those principles specifically to specialty care. At the second half of the show, we're going to get into the how. We're going to provide examples of how you do it. And then finally, during the end of the show, we're going to talk about outlining sort of the blueprint on how to apply all of that with a few more examples included in all that. So we have a jam-packed agenda. You do have that Q&A module at the bottom of your Zoom application. If you're watching live, we will try to get to a couple of questions, but fair warning, those of you that submitted questions when you registered, we've already grabbed some of those, and those are going to be the ones that we're going to incorporate into the flow of today's show. All right, we're going to start with the 50th largest state in the U.S. and Rhode Island. And Nick, thanks for doing this. Nick, again, Senior Vice President, Value-Based Care, Contracting, Data, and Analytics at Blue Cross Blue Shield of Rhode Island. Let's start with you, Nick, and talking about the core principles to a successful value-based care strategy for any plan.
Yeah, well, first of all, Eric, thank you for having me. We may be a very small state, but we are a really exciting place when it comes to value-based care and specialty value-based care. So I think it's important to start with a little bit of background on the landscape of Rhode Island. We at Blue Cross Rhode Island have 80% of our Medicare membership in an upside-downside value-based program. About half of that is in a global cap, so the provider's taking 100% upside and 100% downside. And we have about 65% of our commercial membership in similar upside-downside shared savings arrangements. So it is a great foundation for value-based care. Most of that attribution is through PCP attributed ACOs. And that creates it creates a foundation for how we deliver value-based care and opportunity to, I think, to innovate on how specialist value-based care and primary care value-based care work together. We take the approach where we are very supportive of our providers and of our network. We have the contracts in place, and we try to meet our providers to be successful in all of those value-based contracts through investing in capabilities. And we try to partner with those providers to understand what capabilities would be most helpful for them, and have open dialogue with them around where we're making investments so that they could eventually continue to be really successful in their value-based programming. I think a really good example is data and analytics. We have a team that partners with all of our value-based providers to drive insights into their data and where we think their opportunities are. We are very transparent with our data because we think visibility and transparency in data is an important tool to success. And we've actually made a big investment this year into an industry-leading data and analytics platform that's actually going to allow our providers to access their data on their own. It's like self-service login, full access to Blue Cross Blue Shield Rhode Island claims data. So that's our approach. We try to support our providers as much as possible to be successful in our unique value-based care footprint.
So I want to unpack that a little bit. So it sounds like, yes, okay, the Rhode Island market is fairly mature relative maybe to the rest of the country, but the principles of meeting providers and talking to the providers about their business is paramount to maybe building that maturity in the market, right? So I'll call it provider empathy. I know we kind of played around that term when we met prior to the show. Could you speak a little bit to the commitment the organization has made in caring about the provider's business and not necessarily thinking about it through the lens of MLR and all the things that the payers do have to worry about in order to build that partnership?
Yeah, well, we think it goes hand in hand because our providers are taking on a material amount of risk. Strong performance in MLR and supporting our providers and making sure our providers have the appropriate economics through value-based programs. Those are all the same conversation to us. And so if we talk to our providers about where there may be outlier costs or where there may be opportunities for more efficiency with some specialist care, those are very open, transparent conversations where we're trying to position them to be successful because we see the incremental economics that value-based care can provide to our network, along with all of the great improvements in quality and outcomes and access for our members. And so I think we have different types of ongoing collaboration with all of our ACOs, but they're all targeted at the same thing, which is identifying where there are opportunities, figuring out how we can best support them, figuring out their particular investments that we can make or make together to position them for success so that their ongoing long-term success in value-based care is sustainable.
Great. So we're going to stay on core principles. And folks, I know some of this isn't brand new breaking news, but I think it's really important to understand the principles and actually applying the principles. So I'm going to summarize sort of the first half of our core principle kind of segment here as you need to take a provider perspective. I'm going to call it provider empathy. I'm going to go trademark that. And to execute on that, collect the data, share the data, be transparent with the data so there truly are business partners with you. Now, I'm going to shift over to Dr. Alex Ding. He is the Associate Vice President of Physician Strategy and Medical Affairs at Humana. Humana, Alex, has had a long history in value-based care. Can you talk a little bit about that history and maybe how you're looking to apply this in extension beyond primary care?
Yeah, absolutely. And thank you for having me join you today. Really excited to be here. So we at Humana do consider ourselves a leader in the advancement of value-based care. And many of the learnings that we've had over this past decade plus have taught us a number of insights. So Nick mentioned his MA membership penetration. We've got about 70% of our Humana MA membership under the care of a PCP and a value-based care arrangement with us. And we've learned that value-based care can be such an essential driver of that triple aim in healthcare. So we publish an annual report that shows our data that shows lower costs, fewer unnecessary ED visits, and fewer unnecessary hospitalizations, better patient experience. And then I think talking about provider empathy, given the epidemic of clinician burnout, we're also seeing evidence that value-based care can lead to better provider experience, stronger financial performance of practices in value-based care, and really showing that value-based care can address the quadruple aim in healthcare. And so many of the principles that value-based care incentivizes and enables are, really quite evident in terms of why they would lead to better patient care. So this includes a more holistic approach to the patient and their care, really more genuinely more patient-centric. You've got an entire team of healthcare professionals taking care of not just the one patient in front of you, but a whole population or panel of patients. As a result, we see greater patient engagement, greater care coordination, more thoughtfulness about resource utilization, and more wraparound services to addressing health-related social needs in addition to clinical care. And I think all of these features and how to actually operationalize and run these models, we've also leaned on from those learnings to build out our own value-based care primary care clinics under the CenterWell brand. So similarly, I think we've also learned that value-based care is not a one-size-fits-all sort of program, and we've got to meet practices where they are, just as Nick mentioned. And so we've developed a value-based care continuum that really ranges from quality bonuses to upside risk only to global risk. And we're looking to apply the same type of continuum model to specialty practices as well. And I think within specialty care, there's kind of also a continuum, which is how you consider how broad that bundle or that episode is. So we're moving from a piecemeal fee-for-service per service type of model to one where there's more shared risk for bundled payments for something like a joint replacement. But then as we're working with more sophisticated risk-bearing organizations, it's about how wide do you want to zoom out that aperture. So for example, with a MSK value-based care arrangement, we can think about more broadly than just a surgery with a joint replacement, but about all of the management surrounding low back pain, for example, or for kidney care, it's not just management around dialysis dependent patients, but how do you actually take earlier stage CKD, prevent and delay the advancement to end stage renal disease? And so, in the past 10 plus years, we've seen value-based care go from concept to practice, both on the payer side and the provider side. And I think we've made some pretty deep inroads with value-based care in our MA membership. And we're looking to take those learnings to see what's next, to see what we can do with the next 10 years. So we think there are opportunities in Medicaid. I think there are so many health-related social needs and health inequities that would be such an opportunity and need in this particular population. We're also growing as a health services provider and looking to apply those value-based care sorts of principles on the delivery side of the house. And then, of course, looking forward to exploring more the conversation and theme of today, which is how do we take these principles in value-based care to really expanding them into specialty care.
Right. I mean, in many ways, you're taking the bright spots from your primary care model and trying to apply it both to you've already have applied it to your own delivery system in CenterWell, and now looking to apply it with specialty partners as well. I love this. And incidentally, I failed to mention this at the beginning for everyone. So Dr. Ding is also a practicing interventional radiologist. So maybe later on, I'm going to ask you to take off your Humana jacket and maybe put on just your specialist jacket. So we'll get into that a little bit later. Okay. All right.
Yeah, absolutely.
Let's get into like the applications of specialty value-based care. I'm going to bring in Rachel Winokur, Chief Executive Officer at TailorCare. Rachel, why is specialty value-based care so hard? And maybe if you can share with us, what are some of the more innovative organizations around the country doing around new partnership models?
Sure. Well, thank you again, Eric, for hosting this and for bringing all of us together. I've had the pleasure actually of getting to know Nick and also working with Humana through this process. And so you brought the right people to the table for this discussion. So with respect to specialty value-based care, the challenges are really around capabilities and experience. Most often than not, the historical focus, as you're hearing, both Alex and Nick are talking about their commitment to value-based care, which is fantastic, which is why they're organizations that I think are leading the charge. Historically, the focus has been really around broader population, those with high acuity clinical conditions, medical needs that tend to be more clinically acute. There's often limited time and really a lack of appropriate incentives for providers to be able to adequately address a patient's full clinical needs. So some certain specialties just get pushed by the wayside. MSK, obviously a condition near and dear to my company's heart, which is really around pain and quality of life, often are never addressed within a traditional or a typical visit. And so what happens from a clinical delivery side is that many specialties are just unaddressed. And so when you think about specialty value-based care, you need to bring those conditions to the forefront of the clinical delivery system, which means that you really need to have both a payer and a set of providers who are focused on this alone. And that's been challenging for many payers who really have big fish to fry with respect to risk-based primary care. As you're hearing, 70 to 80% of primary care practices are managing risk populations. They have a lot of wood to chop to manage those people. As I mentioned, we're working with Humana in Atlanta. MSK there is a top 3 area of spend. Historically, COVID has been a real strange I'd say, impact, has had a strange impact on historical trends. There's been a lot of pent-up demand. What we're seeing across all the payers is really medical trends going up. So MLR reduction is a really important driver, but equally as important is patient satisfaction and CAP scores, which drive to and are leading also into their STARS ratings. So what Humana and we work together to create a partnership to really offload all of the MSK risk for their entire population in the market. And what we do, we provide all the navigators. So we provide physical therapists, we provide RNs, care advocates, and we bring patients into our program through a variety of channels. We stay with them through the process. And what's important is that a plan's network and the clinical solutions that they may have that are actually addressing some of the clinical needs of this population are brought into the program. But the program is critically integrated within the plan's existing solutions, within the plan's existing network, within their utilization management programs, et cetera. There's an added benefit that often programs can provide, because when you're spending all of your time talking to patients about a specific area, you find that you actually end up identifying other areas that still may not be addressed or identified through the plan. And so what we find is that we are able to identify other clinical conditions and we refer that back to the plan. And all the outreach is done by our company. So the plan benefits from actually not having to allocate resources to bring and engage people within the program.
Tell me, so it's fascinating, and I mean, the key obviously is taking a consumer-centric approach and providing a high touch but meaningful and intentional experience. I mean, that's kind of how I interpret what you just said when you talk about the navigators and the individuals who are actually touching that consumer. Could you talk a little bit about the strategy that you and Humana specifically have taken in Atlanta around provider network strategy?
Sure. I think network is a really critical component of the model, and it is also a very complicated area of focus for any given plan. And that's largely because plans generally need broad networks to support all of their customers. However, a network performance varies. There's high variability across providers, even within a specialty and a network. So what we actually have found works best is we leverage, I hear Nick talk about the data that they have access to, and we're seeing the same with Humana. It's really important to bring together data that's coming from the existing plan with our data that comes from that we both can access externally, but also have developed internally. That allows us to really identify high-performing networks. So we effectively tier a network without having to plan tier the network, because tiering the network is very complicated and it can create a lot of abrasion within the market, which plans, understandably so, do not want to do. We then are able to use that information to understand both performance, but also other characteristics of the network that allow us to match patients appropriately. And so we're not matching patients who come in the door for whom we screen, and we understand what clinical needs they have and what is appropriate care. We also then assess what is the appropriate network match for them. And we then actually have developed a ground game where we've built all the relationships with those networks, even if we're not actually directly contracting with them. And we schedule directly on our patients' behalf with those providers. And we stay with them throughout the process. And that's really important because it creates a very personalized experience, and it allows us to really push people to the networks that we believe perform best, which drives both the economic outcomes, but more importantly, the clinical outcomes.
Now, how are you doing that matching?
We do it through all of our data. So we have our navigators who have access. We do a lot of pre-screening. So we screen our patients. It takes about 30+ minutes, depending on the clinical condition and how many body parts, et cetera, that a patient presents with. And we also understand their needs. So there is an understanding based on evidence-based guidelines. What is their appropriate care? Is that care a surgical specialist? Is that care a physical therapist? Is it somebody who's focused on pain? Is it fall prevention? We then go through our data, and we have models that effectively spit out to us based on those characteristics, but also softer characteristics. There's geomapping. There is really around what type of provider is better suited for a patient of this set of characteristics.
Yeah.
And then we match them. And then we schedule. We reach out and we schedule directly through
sounds like that's just a phenomenal step forward in what's often be the best practices around navigation right now. So that's terrific to know that technology and that process is in place. I want to move over, and I want to hear how Rhode Island's kind of applying these specialty practices from their primary care model to the specialty model. But before, I was just thinking about this. Gene, why don't you throw up a poll? So there's an article that Rachel wrote that I got to read in preparation for this that actually outlines a lot of what she just said. So if you want like a cheat sheet from what Rachel just talked about regarding how plans can do all of this, there's an article that she wrote called the 3 components that lead to better outcomes, and it outlines a lot of what she just said. So I think it'll be a really good take home for all of you. It's not I mean, I guess it's a commercial that Rachel wrote, but it's really not a commercial. It's really all the details that were just said there, almost like it was transcribed. So I'm just looking over at the article now as I'm pulling it up because I read it prior. Yeah, I think let's do that, Gene. It's a good fit. So we'll let folks, if you want a copy of this, I'll send it out to you. If that's okay, Rachel, I'm just going to take this PDF your team sent. I'm going to send it right out to everyone, and you'll get that. Nick, let's talk. And by the way, if you're listening on your podcast, we'll provide a link in the show description so you could request it if you want. Nick, why don't we now come back to Rhode Island? Like, how are you taking all this strong PCP value-based approach like you heard Humana talk about as well, and how are you extending it to specialists?
Yeah, thanks for the question. So I think we're trying to take the same type of network first approach that we take in primary care to specialist care. And we've seen the success in our primary care ACOs, and we're using that to have a more detailed conversation with the different specialist groups in Rhode Island to identify where they have opportunities where we might be able to do some type of value-based arrangement directly with them. We call that a network first approach. And we are seeing, I think, more and more engagement from multiple different specialties and willingness to engage with our data and analytics to understand where there may be certain opportunities to better manage spend and then share those savings back with those specialist groups. I think the conversation gets really interesting when you take that network first approach and you combine it with some of the comments that Rachel was making about kind of experience and expertise and capabilities when it comes to value-based care. Because a lot of times it comes back to a willingness of the provider to explore value-based concepts, but a lack of capability that exists in their historical practices to confidently take on risk and be able to perform in that risk. And I think the conversations we have all the time are, okay, so we're happy to do a value-based contract. How do we also pair you with the right capability to make sure you're successful? Is that something that we can do together? Is it something where we need to bring in some type of third party to make sure that you have the right capabilities to be successful?
So Nick, how do you do that at scale? I mean, do you like have a consultant at Rhode Island that comes in and meets with the specialist? Because the lack of, I could see people wanting to do it. You know, if I'm running my own practice, and we'll get a little bit later on with Alex on this, you know, as a specialist, like, wow, seems good. I could see maybe some upside. How do I pull that off?
I think you have to understand the scale of the Rhode Island market, right? We're a really small state. And so when you're talking about a certain specialty, you're often talking about 2, 3, 4 groups that are going to make up 75 or 80% of the market share. And so you can have those individual conversations, a much different dynamic than something like Dr. Ding would be dealing with across the country. And
can I actually let me actually I'm gonna have you leave Rhode Island for a second, and you're gonna have your own really highly acclaimed consulting firm. So, and you're doing really well, by the way. And what would you do then if you were going into a bigger state? And I'll choose Texas.
Yeah.
And you had to figure out how to take the principles in Rhode Island. Now you don't have the luxury for a health plan and do that sort of a similar thing. Is there a way you would start with like an 80-20 kind of strategy with the frontal off?
Yeah, I mean, I think I would do a similar type of thought process that we have here, which is, are there providers that have enough scale in the market and enough interest in value-based care that you can just do a value-based care program directly with them, and you can understand where their unique opportunities are and then share those savings back to them. Once you get past that, then I think you go to the broader question that Rachel started to hit on, which is you have all of these other organizations that are building a lot of impressive capabilities in specific diseases or specific conditions. And I've seen it firsthand, because before Rhode Island, I worked for 10 years at DaVita running commercial CKD and ESRD value-based programs. There are really impressive capabilities that are condition specific. And so bringing in somebody who can help support the advancement of value-based care in that way can be a really powerful strategy. What we've seen is that the coordination and the integration and the buy-in of the local network is just super important to make that program successful.
Okay, I got one more follow-up and then I'll let you off the hot seat. Okay. What happens, and I'll let you come back to Rhode Island. Okay? Safe confines of Rhode Island again. What happens if you have specialists in a large practice and you have specialists in the practice, or even if they're sitting outside in a separate practice? And what happens to those primary care docs when you're potentially pulling funds, their bonuses to pay the specialists? Like, how are you managing that dynamic?
Well, I mean, I think the goal is to make it all work together. So if we have the foundation of a primary care ACO, and we are able to structure a specialist value-based program that naturally has some overlap in that population, ideally what we've done is we've structured a specialist value-based program that is successful in driving a lot of savings, that is driving savings to that ACO. And then there are obviously complex, shared savings calculations that you have to manage between the different programs. But, the most advanced value-based care providers that I get to work with, they say, look, if we're going to bring somebody in who's going to help support value-based care in a specialty and help lower costs overall, we are all on the same team together, and we'll figure out a way to make it all coordinate and work.
I imagine there has to be a dynamic, and you could tell me if I'm just being a little bit naive or idealistic here, where specialties have their own sweet spot, right? They have their own sweet spot. Even if you're running an orthosurgery practice or another type of practice where like there's a certain type of individual patient and condition or subset of conditions that they like treating better, they have better outcomes, they just rock it, and maybe it's 60% of their patient suite. I imagine this kind of approach allows them over time to sort of practice what they're doing the best more often, like, because then those cases come up, and then the other cases maybe they don't end up not treating, and so their practice will get filled with more what I'll call, from a business perspective, profitable conditions and procedures versus having to do it all. Like, they could get a little bit more refined in their approach, or am I?
Yeah. Well, I think it comes back to the concept we started with, which is transparency and visibility in the data, which is if you're creating an environment where everyone has access to the data and you can see over time the way that different ACOs or specialty groups are performing, and where there may be better outcomes or worse outcomes on specific procedures or specific conditions, or more efficiency or less efficiency, I think you're going to see a lot of the value-based operations and the care delivery naturally steer members who are going to get better care from higher quality providers, or at least for specific conditions over time. So I definitely agree with that.
Okay, my curiosity got the best of me. Now we're behind schedule. Sorry. Thanks for indulging me. So, Alex, let's go back to Humana, and I know you touched upon this, so if this is a little bit redundant, let me know. But those key enablers of value-based care that you've learned from working with your primary care practice and the CenterWell experience and all that, how are you thinking those can be applied to your specialty care strategy?
Yeah, I would say one of those key ones, which maybe I'll just double click in on a little bit more, have been alluded to by both Rachel and Nick, which is data and analytics and that entire infrastructure that's needed. And I would also go back to another principle that Nick mentioned, which is understanding where practices are, taking them as they come and working directly with them, understanding what their capabilities are or what their lack of capabilities might be for them to get into value-based care, and supporting them in that process, and supporting them in developing those capabilities. So, kind of in recognizing that critical component, Humana developed a homegrown population health insights and management IT platform. It's called Compass. This tool basically pulls in data from various different sources on our members and provides actionable reporting of insights. We provide this platform for free to all of our contracted PCPs. It really provides up-to-date data such that you might know when your patient has been admitted or discharged, so you can follow up in a timely manner, or which patients to proactively call in for an appointment, or who to follow up with to close gaps of care, or how you, as a clinician, are performing with regard to reaching your financial rewards for the practice. And so that access to up-to-date data is really a critical enabling factor that I'm certain will carry through to specialty care. And so we've also invested more heavily into broadening that, which is into interoperability, including co-developing with Epic, a payer platform, to really allow for more APIs, more connectivity, more free flow of data, not just with the provider organization in Humana, but kind of with everyone involved in the entire ecosystem, because we know that claims data from payer organizations really can give providers a more comprehensive view of their patients and improve the quality of care. And so we also know that incorporating this information at the point of care can really be expensive and challenging. And so to tackle that problem, we worked with Epic to kind of really map out the payer organization's claims data so that it could be incorporated into provider workflows in real time at the point of care. And we've found that that's led to significantly faster and easier ingestion of data from the provider organizations, such that or to provider organizations, so that they could inform their own population health tool. We've heard that they've been able to reduce or reallocate their FTEs, because what was a lot of manual work before is now kind of automated as a result. And that's resulted in some improved identification of some conditions that were previously unknown. It's resulted in better medication reconciliation, better documentation. And so while we have our own platform, I think we're also very cognizant, again, going to the concept of provider empathy, of the challenges of having different payer IT platforms. And we really think this investment in interoperability will allow for more payer agnostic platforms, such that practices have more useful and actionable data for their entire set of patients, regardless of that payer contract. We really don't want data silos to prevent the more widespread adoption of value-based care. In fact, we don't see our leadership there as kind of being a moat or competitive advantage. In fact, we'd love to see kind of the entire industry go down this road together. And I think interoperability is one of those things that you'll see not only enabling that in value-based primary care, but certainly in value-based specialty care as well.
Yeah, by the way, provider empathy is now trending on social media.
Love it. I love it.
I have a quick kind of, I may be putting you on your spot here, Alex, so you may not know the answer to this, but I will like, so you mentioned Compass as far as creating better workflow between payer provider. You mentioned the Epic sort of point of care, I'm going to call it integration / tool. I'm going to just wrap that into, I'm sure your comms people will be thrilled, the Humana point of care kind of initiative or program. And you said since you've been doing that, you're seeing a lot more positive results, especially undiagnosed or undiagnosed conditions being caught. Is there any statistics or data you could share with us since you've applied this sort of point of care program or raised the bar on the point of care program, whatever we'll call it, that you could share with the group, like since you've integrated Compass and the Epic program together to give people inspiration and potential results they may realize?
Yeah. I have some of the qualitative sort of results that I just mentioned, but unfortunately I don't have any of the numbers behind it just with me.
I figured it makes sense. Okay, great. Sorry, I'll take you off the hot seat.
That's all right.
So one of the things, quick little analogy, trust me, I'll connect to that here. Sounds like I'm going off the rails. So last summer, I take my family for the first time to Yellowstone. We're not exactly a rough and tough hiking family. We go on a trail, we get ourselves lost. There's no cell service in many places of Yellowstone if you've been there, and we're kind of screwed. And we randomly run into a couple that happens to be professional hiking guides in that area, and we got to talking to them. We told them our plight, and as they got to know like what my daughters were looking for and capable of, they literally guided us to exactly where we should be going to see the sites that were sort of within our reign of capabilities. And so like we would have been trapped, right? And so, but we found these guides by accident. So, and I think about healthcare very much like that too. I really do. Like my parents, they often are calling me, like it's complicated as they navigate their way through. So imagine if you had an imaginary tour guide getting you through these hikes, and that's who TailorCare is. And I want to give you some details about them because without them, and companies like them, we can't do the show, and they are a perfect fit for this episode, as you could imagine. And they, as I said earlier, are a risk-based navigation program, and they provide these deeply personal support, just like those hiking guides provided to me and my family, to patients who are living with joint, back, and muscle pain. And they combine a careful assessment of those symptoms, as you heard from Rachel earlier, the health history, their preferences, and their goals, and they provide that with predictive data, combining all of that with the latest evidence-based guidelines. They're able to help consumers struggling with those symptoms and those conditions to navigate the most effective treatment pathway every step of the way, improves their experience, their NPS, CAPS. You can imagine the impact there if you're a Medicare Advantage listening. And of course, it's going to obviously provide better outcomes from a business standpoint, outcomes as well. So check them out at TailorCare.com. But this is what I want to do. I don't do this a lot. If you want to meet Rachel, the author of that article that a lot of you just requested, or her team, just to pick their brain on navigation and the combination of technology and navigation, and just have a call with her. It doesn't have to be a sales call, but just a networking call. We're going to put up a poll. And if you want to meet Rachel and the team, press yes. I'll make an introduction. I won't just hand over your name. I'll make an introduction to Rachel and her team, and we'll do like a little bit of a warm transfer over, and you guys could get tap into that wealth of information. Rachel, I want to keep you on the hot seat since I just teed you up there, and I want to circle back to the Humana in Atlanta because the whole thing around how you do this is all tied to data transparency and building trust. And to do that, you have to have tracking and reporting as part of your model. And you have to be able to understand the impact, right? You heard Alex allude to the impact that some of the programs they've applied are making. Could you talk to our audience about some of the benefits and key results that Humana in Atlanta, Georgia is realizing as they're trying to achieve, better scores across the board?
Yeah, sure. First of all, I have to say, Eric, you should go on the road for us. You have a great way of telling our story. So I'm going to sign you up onto our growth team, and we'll make it work. But onto your question, key results. And this is not just with Humana. We are working with other partners as well. And while every plan and risk-based provider group is different, there are some key factors and criteria that are very, very much on point, which is one, MLR, right? I mentioned MLR trends are not trending well for many large payers, and specifically when you look at specialty care, it's just increasing. So being able to manage that MLR trend is extraordinarily important, and that is one of the key drivers. Equally as important, though, is patient satisfaction, as you just mentioned. And so we measure all of those, and we measure them in a variety of ways. The data transparency piece is very important, as you said, and for us, it's critical in making sure that we're looking at the same information as our partner is looking. Obviously, quality, we have a number of quality measures that we are held accountable to from a performance perspective, and those are things that we're jointly agreed to with our partners. Those quality measures can differ based on the partner and based on the key considerations that they are dealing with within their market. But that's very important, and we have monthly meetings to go through our performance on that as well. You touched on one thing earlier, and actually it was a combination of Nick and Alex's comments around network. And network is, as to your earlier question, a key component of our model, but it's also extraordinarily important from a measurement of success. If we are doing our jobs well, the downstream specialist networks are getting the most appropriate patients for their practice. So Eric, your naive question of, are you actually getting people who are focusing, are you getting providers who are now able to focus on specific sort of subsets of a patient population and doing their jobs better? I don't know if they're doing their jobs better, but I will tell you they're a lot more satisfied because they're not filling their panels with inappropriate patients who really are taking up spots when they could be either in surgery or having a longer term relationship with somebody where they can actually see and drive the clinical improvements. So a network satisfaction is a really important metric for us to measure. And we see that both from the downstream specialists, as I described, and in our case, those are everything, as I mentioned, orthopedists and a variety of other MSK specialists. But it's also from the upstream providers, the referred primary care providers who have historically referred patients with a lack of clarity around where to refer them to. Now they know their patients are actually being well managed. As you heard Alex and Nick say, many of those providers are in risk-based relationships. So the economics and the outcomes are actually driving economics back to them, as well as the satisfaction. They want happy patients. They want patients who they're able to focus on the key medical components and within their practice for those patients, and trust that the remainder of their clinical care is being well cared for with downstream specialists. That's really important. One of the things that we do, which is unique in the model, is that we actually guarantee savings. So that enables a plan to forecast and predict and forecast the amount of savings that they're going to get, which allows them to put that back into plan design. That's really important from an MA plan. When you think about structuring plans, you think about all the different components that lead into an ultimate pricing. And then the last benefit that we actually are tracking, which was, I would say, not anticipated in our program, but has been a fortunate benefit, is that because this navigator-patient relationship actually gets quite deep. This is somebody who does an initial screen, as you mentioned, but stays through the process. We actually screen on other areas. There are behavioral health screens. There are sort of other clinical area screens. There's a variety of things that come out in these assessments. So we're able to navigate those patients back to other supplemental programs that are being offered by the plan, which both helps the patient, but also helps the plan get the most out of the programs that they've invested in.
Oh, I love that. I know I'm going to rush through. I got to summarize this for everyone, folks. So here we go. And Rachel, keep me honest. I'm going to go quick because we're running behind here. So first that you said, which provider satisfaction. Providers are happier providers providing better care. There's all kinds of ancillary benefits there. Patient satisfaction. NPS scores translates to stars if you're Medicare Advantage. Quality of care goes up. You're seeing MLR go down. So there's a business benefit to that. That money goes right back to the network. So they not only make more money, they can invest more money into their network. Network abrasion goes down. And then finally, you're finding opportunities to take individuals who may have another condition or another situation going on, social driver, something of the L, and navigate them to the right place so they could get the more and more appropriate care.
Well summarized.
Okay, good stuff. I'm going to move on. And speaking of happy providers and happy specialists, let's bring back a happy specialist, Dr. Alex Dang. Alex, I warned you this. You're going to temporarily leave Humana and you're going to put on your specialty hat. What has like the right economic and business model for an interventional radiologist as you're thinking about value-based care?
Yeah, I mean, I think most of us can't even conceptually wrap our head around it, let alone understand it in practice just of yet. I think certainly value-based radiology is not something that's widely in practice today. But, as a practicing radiologist and as someone who works in a value-based care forward organization, I do have some of my own thoughts for how we might think about value-based care in radiology. I think maybe it's provocative to say this, but I think it might require some dismantling of the specialty and integrating it more directly with the practice of other specialties. I think it's an opportunity to be closer to referring physicians and to be closer to be part of a team that's managing a condition rather than just being the piecemeal provider of services like interpreting a CT or doing a biopsy and really being disintermediated from the whole of the patient journey. So since we're talking about MSK, you could think about MSK radiologists that are more integrated with MSK value-based care sorts of practices. They can not only do the MSK imaging, but they can do image-guided injections, but then they're integrated and coordinated across with other specialists that are in the field. You got PM&R, PT, orthopedics. And I actually think that that would be good for the patient because it becomes more patient-centric rather than physician specialty centric, which is, how it's grouped together just by virtue of our training specialties. But I think breaking that model can be a hard thing to do since that's how the infrastructure of our healthcare system is built. But I think there's maybe another role for radiologists, which is another opportunity to show value above and beyond just interpreting images or doing procedures. I would say radiologists are the physicians who really understand what the right testing is. They can provide recommendations for what the best test is to address an underlying indication rather than just being told to interpret this particular set of images. I think radiologists are primed to play a role in identifying appropriateness for certain studies. They can play utilization management, a clinical decision support sort of role to really kind of get the payer out of the way and let physicians lead on resource management. I think that unlocks some value. And I think that model would really push radiologists to become more accountable stewards of scarce healthcare resources while at the same time getting the right diagnostics for the right patient. And so I think, I'm convinced that this model would be more professionally fulfilling. I think it gets us off that RVU treadmill that really is burning radiologists out. And I think it would integrate us more holistically into a patient's care and put us more squarely integrated into the care team. And I think that that would be a positive future for radiology.
So that's great. And I want to now like bring back Nick, and we're going to talk about approaches, one approach that maybe works, one approach that maybe doesn't work. Before I do that, it strikes me, as I'm thinking about programming for the rest of the year, and we're not going to get to everything here, folks. And there's a lot of your questions. We're going to try to, I'm not going to get to all of them, but maybe I'll send you some written answers or have some of our panel send you written answers. Maybe we'll do a sequel to this episode. We'll see. To that end, if you want to, I love connecting with you guys about future programming, what you want to hear, and if your organization wants to get involved in programming through sponsorship. So I know Rise is coming up March 17th through the 19th. I'll be down there hosting a panel. If you want to meet with me there, I'd love to connect. If you want to just do a Zoom, great. If you don't want to hear from me, I get it. A lot of my family and friends say the same thing. But if you do want to connect, I'm going to put up a poll, and while Nick's talking, you guys could decide if you want to set up a call with me or a one-on-one at Rise. Nick, let's do your network first approach, which I love that. Let's talk about an example of when you did follow this practice and it's working for your specialist. And let's maybe provide an example of something when you didn't follow it and maybe you're getting friction because of that, to warn everyone to not make the same mistake.
Yeah, thanks for the question. I mean, I think whenever you're trying to bring in a new capability or a new type of value-based program, the collaboration and the buy-in of the local provider network is just critical to the success, right? There has to be ongoing collaboration in order to do the right care coordination, data exchanges, and ultimately drive the outcomes we're all trying to drive. I think I've seen in my role at Rhode Island when, as the plan, if we just try to bring something in and say, okay, we need a new capability in X condition, and we bring it either to a specialist or to the ACO or the ACOs, we get a lot of negative feedback and saying like, that's not exactly what we need, or we have a program that is now competing and you're adding some fragmentation to a system that didn't have it before. And I get a lot of that feedback from our mainly our ACO partners or specialists, depending on the scope that we're talking about. On the other hand, if you can have those collaborative conversations with those providers up front, and you can start to identify where there are opportunities, and you can start to say, okay, we have a big opportunity in MSK, for example, and you can generate the buy-in, and you can start talking to them about capabilities. There's a way to bring in these sophisticated and impressive capabilities in a way that works better. And I've actually, in recent conversations, directed some folks who are trying to enter Rhode Island to say, look, the path to entering Rhode Island is often through our ACO partners or our specialists. And if it's a capability that they think we need in the market and they bring it to me, then we're all in. And I actually have had recently some people come and joint pitch me. We've had a local specialist group with a capability, a value-based capability that was trying to come into the market. They set up time with me together and said, we want to do this. It's supporting the network. It's bringing in new capabilities. Let's figure out how we contract the three of us to make it work. And I think that just sets it up for much longer term success. And having that local provider buy into what are really, really impressive capabilities. I've just experienced those two different paths. When I try to like kind of come over the top and say, here's a new capability, there are some real headwinds to getting that operationalized effectively versus kind of the bottoms up approach.
A good segue. I want to talk blueprint. We have about 8 minutes left. We're going to do blueprint, and then we're going to provide some final examples from Alex to close us out. So, Rachel, you heard like there's a part of a blueprint that Nick just laid out. But if a health plan was going to begin to expand their value-based care strategy beyond primary care, like where are they going to start, and what are some core components that they want to put on a whiteboard as they're thinking about their initial blueprint to actually execute on this? Let the people who are listening and watching be able to come back out of this with some action items.
Yeah, so there's a few things. As I said, not every plan is the same. And so I think there's a lot of internal assessment that a plan needs to do. One, the competitive dynamics, the market share, sort of how that plan is participating in a market, looking at their provider composition, as Nick described very well. Providers are a really core component of any kind of program. What is the degree of EBC adoption, and how willing are they to participate in a program? Also understanding really kind of the MLR baseline is what does this plan look like within that market? And then understanding, really, kind of what their objectives are. So are they really looking to reduce MLR? Are they looking to drive improvements in patient satisfaction? And being able to set those clear objectives. The other, I think it's really important as we talk about network, and as they do the assessment of their network, to really be honest with themselves around the performance of the specialty network. Again, you've heard a lot of talk about the data side of things. Not every plan has the same amount of data that you're hearing from Humana and Rhode Island. And so that's really important, because without visibility into how a specialty network is performing, it's really hard to understand how to navigate through there. And levers and other components of, bundle programs, et cetera, can work, but they're really hard when you don't really know how where you're getting the referrals going to. So that's really important. And then I think we talked about tiering. How do you actually tier your network and navigate through your network without actually tiering in and creating that abrasion? This is where most payers struggle. They don't have the data, as I mentioned. They often don't have the appetite to put the risk of network abrasion there. And they have, in many cases, point solutions that they're really having a hard time, that's difficult to put together seamlessly in a population, right? So they've invested in a variety of different clinical opportunities and programs, but they don't have the ability to navigate somebody or payers or providers through them. So this is where we step in, because what we're finding with our partners is that they have come to us because they've had these challenges, but they are having these key issues, which is, again, MLR or patient satisfaction, and they are looking for a program that leverages their existing capabilities but layers on top of that. And so one of the things that is important to us is, you've heard Nick say a lot about the provider-centric piece, but it's also around the payer-centric model, the patient-centric model. And so our approach is very focused on bridging their solutions together, making sure that their network is a key component of it, both as I mentioned, the upstream primary care referrals and the downstream specialists that are delivering the specialty care, and knitting together the programs that they've developed thus far. Once we do this, and once we have built this sort of combined or aggregated the specialist network, we then define the clinical model, and we also build out a patient engagement model. And that is critical for the success of any specialty value-based model. You need to be integrated within the existing care delivery system, as well as you need to build pathways to engage patients within the context of their care journey. You can't take patients out of the clinical model, and you can't build around what a payer has already built within their programs. It's not going to work. You're not going to get the investment. You're not going to get the engagement, and you're going to find a lot of frustration on behalf of both the payers, the providers, as well as the patients. So this is also a struggle with payers because it's a ground game. You've got to, you've really got to build the relationships, and obviously payers have very tight relationships with their network providers, but it is a different type of relationship. It's not a contracting, reporting relationship, but it's actually a, spending many hours in the office, educating, integrating with the clinicians, understanding who does what well, so you're able to navigate and match right to that. Enhances the data that we have, is the data that we aggregate from a ground game. And we also need to engage the right patients at the right time. And that's really important from a patient satisfaction perspective. And so, one of the things that's, I think the last piece is that and maybe the big takeaway is when payers are evaluating a specialty value-based care strategy, they need to be honest with themselves and ask the questions. Do they have the capabilities to pull it off? Do they have the data and analytics? Have they built the network relationships? Are they able to maintain this ground game relationship? Are they able to work closely and have the navigation investments on their patient population or the member population? And do they have the willingness of their organization to invest and dedicate the resources to bring this all together? Many cases, this is a specific clinical condition within a large population, and there are many sort of demands on a payer's dollars as well as the clinical resources. And so the prioritization has to be really important. Those decisions are critical. Once you can do that assessment, and truthfully, we work with many payers to help them through this assessment process, because it's not always clear what it means to be able to do any of these things well. We then figure out how are they able to successfully do it on their own or not. And some can, and that's wonderful. It's, to me, the benefit of what we're doing at TailorCare is not specific to the business of TailorCare, but is to actually alleviating the pain and functional issues of MSK patients who historically have just had a lot of unmet needs.
Good stuff. To my production team, maybe that's a reel that we'll distribute in a few weeks. There was a lot there. I don't have the time as I'm looking at the time here, because we're really strict with time on listing all of them, but I got about like 9 of them. Maybe we'll post that in a few weeks on social media. I want to thank the 3 of you for all the prep work and time to prepare for today. This was a great conversation, and we certainly could have talked for another hour for sure. To those of you who had questions that get answered, I'll try to get back to you to answers for some of those questions via email. If you haven't seen the email that I already sent you during the show, which is to get your feedback on today's episode, you could complain that I went a little bit long potentially. We like your candid feedback. It directs how we produce these shows in the future. They're really important to the growth of Bright Spots in Healthcare. And I thank you all for listening and watching, because I know you're really busy and an hour of your time is really valuable. And I never take that for granted. So I hope we delivered some value for you, some bright spots for you that you could take back to your organization and apply it. So thank you to all of you. This marks the end of today's episode. Remember, everyone, this is your Bright Spots in Healthcare podcast. Take care, everyone.